Okay, welcome back, and we are going to continue now with part two of nervous system disorders. This lecture will not be quite as long as the first. That was a pretty long one, so it'll be a breath of fresh air to know that this one should be about half the time. So we're going to start off talking a little bit about some congenital disorders, hydrocephalus, spina bifida, and cerebral palsy. So hydrocephalus, when we look at the word, it's hydro, water, cephalus, the brain. So there is excessive cerebral spinal fluid that's accumulating in the skull. And when you have an excessive amount of fluid that can accumulate in the skull, the chances of compressing brain tissue and blood vessels certainly goes up. And when that happens, you're going to increase the intracranial pressure. The cerebral spinal fluid is going to accumulate primarily because there's more cerebral spinal fluid that is being produced than it is being reabsorbed. Okay? If the cranial sutures haven't closed, the infant's head is going to start to enlarge beyond the normal size. Now, there's two types of hydrocephalus. One is called obstructive, right? Non-communicating obstructive hypothalamus. And the other is communicating hydrocephalus. So let's look at the non-communicating or the obstructive hydrocephalus first. So now we have the flow of the cerebral spinal fluid through the ventricular system is being blocked. Now, what's doing the blocking? So this usually results from a fetal developmental abnormality. This can also happen from traumatic birth as well, right? If there is some sort of distortion, or if there's an excessive force at birth, or forceps delivery, or vacuum extraction, these can create a lot of issues with the skull. This obstruction leads to a back pressure of fluid in the brain's ventricles. Remember, there are 4 ventricles. There's 2 lateral ventricles, a third ventricle, and a fourth. We have a picture, so we'll go through some of that kind of quickly for you. It enlarges the ventricles, and when the ventricles increase in size, remember the ventricles are deep within the center of the brain, it's going to compress and push outward, and that can compress blood vessels and brain tissue. So just to review, here's the cerebrum, right? Here's your frontal lobe and parietal lobe and occipital lobe. Here's your pons, medulla, midbrain, cerebellum. And here in the diencephalon, where you have the thalamus and the hypothalamus, we also have the ventricles. So we have lateral ventricle 1 and 2, right? Those are the paired. Then we have our third ventricle, and then the fourth ventricle is here. And if we have a blockage, let's say somewhere between the third and fourth ventricle, and it can't drain into the fourth ventricle, let's say through the cerebral aqueduct is jammed up right here, or the aqueduct of Sylvius. So if this gets jammed up, you're going to have a backflow of cerebral spinal fluid in the third ventricle, and eventually that will push up and back up fluid into the lateral ventricles 1 and 2, and eventually that will start pushing upward, and there's really not too much room here before it starts to hit bone, and it will start to expand that out a little bit, okay, or a lot of it. And what they'll have to do is try and shunt and get that fluid that's accumulating in here and shunt it away, into the abdominal region, just to get it out of there. So the second type is the communicating hydrocephalus. Now, this is the absorption of the cerebrospinal fluid through the subarachnoid villi is impaired. So it's not that it's producing an excessive amount. It's not even being blocked. It's just the absorption of it through the subarachnoid villi is being impaired. So in neonates, the skull can expand to a certain degree to try and, give a little bit of more room. But if not treated, the brain tissue can be permanently damaged. So some of the clinical manifestations, the signs of increasing cerebrospinal fluid really depend on the age of the patient. But one of the things that we can assess is the pupillary response to light will be sluggish. So, when you shine light into the eye, it should quickly constrict. The scalp veins will appear to be dilated. The infant will be lethargic, very irritable. If you pick up the baby, there'll be this high screech, this high cry that's like screeching and very high pitched. The baby is quite lethargic and irritable. And the eyes show this classical sign of what's called the sunset sign, where the sclera is very visible above the colored portion of the eye and above the pupil. I'll see if I can show you a picture of that. So here's the hydrocephalus. You can see the expansion of the skull. You could see the sunset appearance where you see the white of the eye and it looks like the sun setting, right? Like it's going down. Very sad. So they have to put a shunt in here. The diagnostic tests are CAT scan, MRI, that can start to pick up the abnormalities in the ventricles. It can locate the exact obstruction or the abnormal flow, and it'll assess and determine the size of the ventricles. The treatment will be either to remove the obstruction or just to provide a shunt for the cerebrospinal fluid from the ventricle into the peritoneal cavity or just any other site outside of the cranial cavity. So they will refer to that as the extracranial site. And then the shunt will have to be replaced as the child grows. All right, spina bifida, this falls in the area of the group called neural tube defects. This is a common developmental abnormality. It is a failure of the posterior spinous process of the vertebrae to fuse. So the lamina do not come together to form a spinous process. And that can permit the meninges and the spinal cord to herniate through that. And this can result in some neurological impairment. And any number of vertebrae can be involved. I've seen numbers of these through my years in practice. Most pretty much insignificant. Most people didn't even know they had it until I saw it on an X-ray and showed it to them. Now, spina bifida occulta is when the spinous process does not fuse, it doesn't close to form a spinous. There is no herniation of the spinal cord through that gap, and there is no herniation of the meninges through there. The defect may not even be visible. There is some indicators that perhaps a spina bifida is there, where they find a tuft of hair that may be present superficially on the skin over the site. Some refer to it as a fawn's beard, but it's just a little patch of hair. So here we can see, this is the lateral view, right? So here's the lumbar lordosis, here's the sacrum and coccyx, here's the spinal cord, which ends, and you have all these nerve roots at the very end, and these are the spinous processes. But we see that here's a vertebral body, but there's no spinous here. So potentially, this would be a spina bifida occulta, but potentially what could happen in serious conditions is things can permeate outside of this cavity and go right through here, okay? So now we have a type of spina bifida that's referred to as a meningocele. Now a meningocele, you can see the word meninge here, this is a herniation of the meninge that occurs through the defect. The meninges and the cerebral spinal fluid form a sac on the surface. So now here we see the meninges start to perforate through there. And this is filled with cerebral spinal fluid, right? These are the layers of the meninges. Now, probably the most serious one is called a myelomeningocele. This one's more serious. It's the herniation of the spinal cord and the nerves along with the meninges and the cerebral spinal fluid. This has considerable neurological impairment. So here we have the meninges, the CSF, and now we've got some damaged nerves that have perforated through here. The etiology, it's multifactorial. It's a combination of genetics and environmental factors. Excessive radiation can cause it, gestational diabetes, and issues with folic acid, which is why you see here MTHFR. Let me show you what this MTHFR is. It's really a genetic SNP. It's a flaw in how a person can actually start to metabolize folic acid. So let me show you this kind of quickly. It looks like a lot, but let me just explain what's happening. If you look at these, it looks like 3 circles, right? The one in the middle, let's call it the B12 cycle. And then off to the left, we'll call this the folic acid or the B9 cycle. And then over here, we'll call this the B6. So we have B6, we have B6, B9, and B12. Now, right over here, where we have this dark arrow, we have methylene tetrahydrofolate reductase. Anything that ends in ACE is an enzyme. So this is MTHFR, methylene tetrahydrofolate reductase. In a large percentage of the population, people have poor MTHFR, which means they have a poor ability to convert tetrahydrofolate into 5-methyl tetrahydrofolate, which is the methylated form of folic acid, which we need because you see this methyl group right here is going to move in this direction where cobalamin can join with that methyl group to become methylcobalamin. And now there's a methyl group attached to this B12, to this cobalamin, that is needed because it moves in this direction where we have homocysteine, which in high concentrations is very toxic to our blood vessels. It's like liquid sandpaper in blood vessels and can rip them apart and cause strokes and heart attacks. So the body wants to get rid of this homocysteine, and how is it going to get rid of it? It's going to hook up with this methyl that's attached to the methylcobalamin, and now homocysteine becomes methionine, and the methylcobalamin lost its methyl and becomes cobalamin again. So how does this cobalamin get remethylated? Well, it needs this methyl group again. But if you lack this enzyme, you never get the methyl to be a donor to cobalamin. And then methionine gets converted to S-adenosyl methionine, which gets converted to S-adenosyl homocysteine, which gets converted to homocysteine. And once again, we said homocysteine is like liquid sandpaper in blood vessels. It has to get rid of it so it can join up with methylcobalamin to become methionine. And then methylcobalamin loses its methyl. But hopefully it can regain it from this one, but not if you have MTHFR. If you have this mutation, you don't have this, so we have a problem with folic acid metabolism. And by the way, the other way to get rid of homocysteine is converting it into cystathionine, which becomes cysteine. But that is PLP dependent, which is pyridoxal 5-phosphate. That is B6. So that's why B6, B9, and B12 work together in harmony for methylation. If a person isn't methylating properly, then they can get spina bifida. If they're not methylating properly, they can have problems producing neurotransmitters. If they're not methylating, DNA synthesis, RNA synthesis, the ability to produce myelin, the myelin sheaths become really inhibited. You can get cleft palate or hair lip. Things just don't close, like the hard palate doesn't close, the lips don't close, and the vertebra, creating a spinous process, doesn't close. So it's all kind of similar. So what they do when women are pregnant, instead of giving folic acid like they used to do, they would just give 5-methyl-THF, okay, because they were giving folic acid to women, and yet babies were still born with cleft palate, meningomyelocele, spina bifida, and they realized that the moms had MTHFR mutation. So even though they were giving them folic acid, they weren't able to convert it to this, okay? So that's why it says here, for spina bifida, combination of genetic MTHFR and where we saw the folic acid deficits in folic acid. To diagnose it, there could be the presence of the alpha fetoprotein in the maternal blood, and that is leaked from the defect. Okay. The clinical manifestations, the meningomyelocele or the myelomeningocele is visible at the protruding sac over the spine. The neurological deficit really depends on the level of the defect and the status of the nerve tissue, but there will be sensory and motor function issues below the level of the herniation. They become impaired. And the treatment is really surgical repair for that. Okay, let's look at cerebral palsy. This is a motor impairment, and this can happen before birth, during birth, or really just shortly after birth. There's altered brain tissue from malformation. So something is happening that alters the brain's function, especially in the motor capacity. It could be trauma, it could be hypoxia, there could be a hemorrhage, it could be low blood sugar, infections, and a lot of other conditions that we've learned that can lead to necrosis. But the key here is it's a motor impairment. The damage can occur before, during, or shortly after birth. And it can come from hypoxia or ischemia that will create the brain damage to the motor portion. It can be caused by placental complications, difficult delivery, vascular occlusion, which blocks oxygenation, hemorrhaging, aspiration, respiratory impairment in the premature infant. Infections can also create it, and metabolic issues such as hypoglycemia in the mother or the child. So this may be present at birth, during development, or even just shortly after. With cerebral palsy, there's spastic paralysis with that, and that's going to result from damage to the pyramidal tracts, that motor cortex. So that's upper motor neuron lesion. Remember, with upper motor neuron lesion, there's spastic paralysis. With upper motor neuron lesions, there's also hyperreflexia. Any deep tendon reflexes is going to be super jerky. People with cerebral palsy have a type of walking pattern. The walking pattern is called gait. The type of gait that they have is referred to as scissors gait, where they walk on their toes and their adductor muscles are super tight, so their legs kind of cross in front of the other. One really in front of the other, and they walk like a pair of scissors. If you open the scissors and it kind of had to torque back and forth, that's how it kind of goes. See how they're walking on their toes here, and you can see the adductors, the knees are kind of tight together, and they have to swing one in front of the other. Okay, but the toes kind of are pointed inward as they do that. That's called a scissors gait. There is dyskinetic disease associated with cerebral palsy. When you look at the word dyskinetic, you see kinesiology or kinetics, which means movement. Dyskinetic is dysfunctional movement, and that's due to damage to the extrapyramidal tracts, the basal nuclei, and even cranial nerves. It will manifest as either athetoid movement or choreiform movement, which is all involuntary, uncontrolled movements. It just really looks poorly coordinated. They have no coordination of the fine movements. When excuse me, when it affects the cerebellum, they'll have ataxic cerebral palsy as well. Again, poor sense of balance and coordination. When we look at choreiform movements, this is like writhing movements of the hands and the shoulders and the arms, and they move in very, and the hands and the fingers, they move in very awkward mannerism. And I highly suggest, there's some really good videos out there on, let me just clear my throat, give me a second. They have some really good videos out there on YouTube on movement disorders, and there are good instructors and educators and physicians out there who've been around for many, many years that actually perform and demonstrate athetoid movements and choreiform movements and different types of gait patterns, whether it be waddling gait or scissors gait or festinating gait. But most neurological diseases have different type of gait patterns. So I would suggest looking up choreiform and athetoid involuntary movements to see what they look like. I can pretty much guarantee you've all seen them before, whether it be, you know, at a mall or at a beach or just being out in the public. You know, I'm sure you've seen it, you just didn't know how to identify it. Okay, still with cerebral palsy, in terms of intellectual function, it varies from normal intelligence to severely cognitively disabled in a small percentage of the cases. There's also communication and speech issues, primarily because it's a motor issue. So if it affects Broca's area, that is the motor portion for speech, there's going to be difficulty. In terms of treatment, it's very individualized. Most have to do with types of different stimulation to help each individual. There's speech therapy, there's PT, there's regular exercise therapy. There are devices that can improve their ability to mobilize and to coordinate. There's occupational therapy. They're constantly monitoring their hearing and their vision. In terms of chronic degenerative disorders, MS is a big one, and so is Parkinson's. So let's talk a little bit about multiple sclerosis and Parkinson's disease. MS, or multiple sclerosis, is a progressive demyelination of neurons in the brain, spinal cord, and cranial nerves. There's different types of multiple sclerosis, and they all vary in their effects, their severity, and progression. So we'll talk about most commonly what's seen. But MS is marked by remissions, right? It can go into remission for 5 years, 10 years, and then it could be exacerbated and then downward spiral. Remember, it is a progressive degenerative disease. It is a disease where it blocks the myelin production. It's just loss of myelin. It interferes with the conduction of impulses in those fibers. So it can affect motor fibers, it can affect sensory fibers, as well as autonomic fibers. The demyelination occurs in diffuse patches throughout the neural system. So some of the earliest lesions, they'll show up as an inflammatory response. There'll be the loss of myelin in the white matter of the brain or the spinal cord, or even in cranial nerves. I had a patient not too long ago who was complaining of um, kind of like creepy crawly sensation on her lower legs, and she described them as feeling very heavy, like tree trunks. And this is a woman in her mid to late 40s, very, very athletic, into martial arts, no health problems, no really major prior history, not a smoker, eats pretty well, seems pretty fit, and um, the next symptom started to move towards um, visual disturbances where just she couldn't quite explain it. And then she was telling me that she felt like she was losing the strength in her hands, like klutzy, a little bit clumsy. So I started putting the package together, and I said, I'm going to send her for a brain MRI. And she did tell me that several years prior to seeing me, the only strange symptom that she had was weird symptoms with her eyes, and she couldn't quite explain it. It was just visual disturbances, but it was in both eyes. She said she hadn't had it in a few years, and then it just came back, but it just came back with one eye. So when I did the MRI on her, it came back as her optic nerve, only one of them was demyelinated. So um, one of them, her body regenerated the myelin, and the other, it started breaking down a bit. So she had MS. And again, first symptoms being visual, right? It was the eyes. And then it went to the tingling sensation, then it went to the legs, and then it went to the weakness of the hands. So it's a loss of the myelin in the white matter of the brain, the spinal cord, and even can be cranial nerves, which she had. And what they can find on the diagnostic imaging are plaques. They're called plaques. They're larger areas of inflammation and demyelination, plaques. They can develop later, they become visible, and frequently next to the lateral ventricles, the brainstem and the optic nerve, right? Just like that patient I was telling you about, the optic nerve. The plaques can vary in size. Okay, so the large area of inflammation and demyelination that becomes visible, especially around the ventricles, the brainstem and optic nerve, those are referred to as plaques. Um, the initial inflammation may subside. The neural function may return to normal, again for a short period of time, but in time the neural degeneration becomes irreversible and the function is lost permanently. And remember, it can go into remission for almost a decade before it comes out again. Typically affects females twice as much as males. It is autoimmune disease. It is increased in people of European descent. Um, Increased risk for close relatives. And some believe that it could also be triggered by a viral infection, and immune responses are also possible causes. So let's see, what did this young lady have? She had the blurred vision. Yep, that was a early sign. She had weakness of the legs. She explained it to me that they felt very heavy. She had these visual disturbances, and they could have been double vision. She just had trouble explaining it to me. It could have been the spots in her visual field. She just said her eyes just did some crazy things. And she had paresthesia. She had this tingling sensation in her legs. She didn't have any issues with speaking, dysarthria, no issues with that. So the MS distribution, if it attacks the cerebellum, then there's going to be balance issues, and there'll be tremors, right? So the cerebellum is responsible for, let's say, moving your finger to your nose. Hitting your finger to your nose should be a nice, symmetrical, smooth movement. But if the finger starts to shake and tremor when you do it, it could be a strong indication that there's a lesion in the cerebellum. If the cranial nerves are affected, double vision or loss of vision. And when the motor nerve tracts, the peripheral ones, they could be weakness or paralysis. And when the sensory nerve tracts are affected, it can get this paresthesia or this prickling or burning sensation in the extremities. There's no definitive test, but history is important, a good thorough exam, MRI for diagnosis and for monitoring to see if it is in remission, if it's progressing, or if it's stabilizing. There is no one definitive treatment, but it's a combination. It's a combination of using chiropractic, physical therapy, occupational therapy. All right, let's look at PD at Parkinson's disease or paralysis agitans. This too is a progressive degenerative disorder that affects motor function. The dysfunction, it is dysfunction of the extrapyramidal motor system. It is degeneration in the basal nuclei. So it's an imbalance between excitation and inhibition of the basal nuclei. There's degenerative changes in the midbrain, specifically an area referred to as the substantia nigra. The substantia nigra releases dopamine, and dopamine is a neurotransmitter that is involved with muscle tone. So when there's an issue with that, the muscles become very, very rigid. The individual starts to tremor and they start to shake even when they're at rest. They call them resting tremors. It's very difficult for them to initiate movement. Let's say they're standing and they want to take a step. They have trouble taking that first step and initiating it. So they have to almost lean forward as if they're going to fall forward. And as they're moving and falling, it allows that leg to move, and they have this very rapid, festinating type of gait where they take these shuffling steps, like very, very small shuffling steps. And then they can't turn around very easily as they're walking. Like most of us could just stand and pivot and do like one spin to turn around to walk back in the other direction. They have to stop and then again, these small little pattering steps as they're rotating their body. That's how they do it. So it usually develops after the age of 60. In terms of males and females, it's probably equal between both. There are some genetic factors, some toxins that can cause it, some viruses that can trigger it, trauma, vascular disease, swelling of the brain or encephalitis, and it could be drug-induced as well, Parkinson's. Some of the early indicators, muscle weakness, fatigue, decreased flexibility because the muscles become stiff and rigid and hard. There's not a lot of facial expression, so they have what's called this mask-like look of expression on their face. They just don't move their face very, very much. They can't raise their eyebrows or smile. Their muscle tone is very, very poor. So mask-like look on their face. They have tremors in their hands when they're at rest, and as they start to move, you can see these pill rolling motions of their hands. And again, I would suggest going on YouTube and typing, pill rolling, tremors, Parkinson's disease, just so you can actually get a good visual of what these look like. So tremors of the hands, the feet, the face, even the tongue. I'll often do this as part of my neurological evaluation just to see if they can hold out their hands and see if they can hold it steady, holding out their tongue, see if it tremors or shakes, their lips to see if it tremors or shakes. Do they have good finger to nose awareness, or touching their finger to my finger, is it smooth and symmetrical, or do they shake? Sometimes I'll have them move their finger to touch my finger, but I'll have them stop about an inch before touching my finger and see if I see a tremor of it. Difficulty initiating movements, increased muscle rigidity. They have this standing posture that's somewhat stooped forward. They just lean forward and they have this propulsive gait. So it kind of has this type of movement. Their head can also shake. They have this mask-like, expressionless look on their face. They're stooped over. Their muscles are very rigid. Their arms are somewhat flexed, or their elbows, I should say, are flexed. Everything kind of shakes, and they take this very small shuffling type of step, but they lean forward, and just by leaning forward, it kind of throws them off balance so they can walk a little bit. It makes them prone to falls, and that's really not a good thing. Also with Parkinson's, their voice is low. It's kind of devoid of any type of tonal inflection in their voice. They can have dysarthria, meaning they have this like scanting speech. It isn't smooth and symmetrical and flowing. It's very scanty, kind of like a tremor in their voice. They can't connect the words very well. Chewing and swallowing becomes difficult, so that eating time becomes prolonged. They'll have a mask-like look on their face. Blinking is reduced. They have this blank staring look on their face also. For the treatment, it's a dopamine replacement therapy, or they'll use levodopa or L-dopa, which is a dopamine precursor, and they use anticholinergic drugs and speech therapy and physical therapy, and chiropractic is very important to help send afferent signals to their brain. It helps to improve their balance and coordination. These are things that I'm checking all the time in my office, pre-care and post-care. I'm always checking balance, coordination, especially of the elderly, because we want to make sure that they can remain independent for as long as possible. So I'm always checking things like, can they sit in a chair without using the armrest? Can they get out of the chair without using the armrests? Can they walk 10 steps, turn around and walk back to me without losing their balance? It's very important to do these things. If I have them close their eyes, can they stand, or do they start to drift? Can they stand in one place and then march with their eyes closed without moving? Or do they have no awareness of their body and they start to drift in one direction? So balance, coordination, knowing where their body is in space and time is very, very important. ALS, amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, myasthenia gravis, and Huntington's disease. So amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease, amyotrophic literally means muscle wasting. So trophic, right? Trophic or hypertrophic or atrophy. Myo is muscle and A is without. Lateral sclerosis is hardening of the lateral corticospinal tracts. There are genes on various chromosomes that have been linked to this disease. It's higher incidence in males, usually after the age of 40. And this is a progressive degenerative disease that affects the upper motor neurons in the cerebral cortex and the lower motor neurons in the brainstem and spinal cord. So it's both upper motor neuron lesion and it's lower motor neuron lesions. The loss of the upper motor neurons in the cerebral cortex, possibly due to the astrocytes. Remember the glial cells? So it's possibly due to the astrocytes producing a neurotoxin. That's going to create spastic paralysis and hyperreflexia. Those are often seen with upper motor neuron lesions, whereas the lower motor neuron lesion creates the flaccid paralysis, the decreased muscle tone, and hyporeflexia. The sensory function is maintained. There's normal cognition. The eyes are normal. It doesn't affect cranial nerves 3, 4, 6, which are involved with eye movement. Death occurs from this due to respiratory failure. Initially, the weakness and atrophy start in the upper extremity, particularly in the hands, and then it can work its way down. They can stumble, they can fall, they get muscle cramps and twitching. The weakness will progress throughout their body. It does affect their speech. They have dysarthria, and swallowing becomes an issue. So whenever patients are between that age of 40 and 60 and they tell me like they have difficulty when they're eating, swallowing, I never take that lightly. I mean, it could be something that's not super serious, like a bone spur around the cervical spine, but for that we can always x-ray and see if that's impeding the esophagus. But ALS is something that we need to rule out. The treatment, there really is no specific treatment that can slow down the degeneration. It's respiratory therapy, good healthy nutrition, speech pathology. Again, you see the occupational therapy, the PT, the chiropractic, and psychological treatment for ALS. Now, myasthenia gravis, this is an autoimmune disease that impairs the acetylcholine receptors at the NMJ. Remember the neuromuscular junction? The junction between the axon terminal, where the end bulbs are, and those end bulbs store neurotransmitters. The one that's always excitatory at the neuromuscular junction is called acetylcholine. So myasthenia gravis is an autoimmune disease that impairs the acetylcholine receptors at the neuromuscular junction. This one affects women more than men between the ages of 20 and 30. The smaller muscles of the face are the ones that are commonly affected first, and usually the eyes. So there are auto antibodies to acetylcholine receptors that form, and it destroys the receptor site. It's going to show up with skeletal muscle weakness. Primarily the facial muscles and the ocular muscles are the ones that are affected first. Dysphagia, there can be difficulty with speaking, and aspirations are certainly a problem. Aspiring objects into the lungs can become a problem as well. Muscle weakness in the face and eyes are the clinical manifestation. Fatigue develops from muscle use, and there could be impaired vision, diplopia, and lidosis. We went over what ptosis was, the drooping of the eyelid. The speech becomes more monotone. There's going to be difficulty with chewing and swallowing. And when it affects the neck muscles, the head just droops and the arms become pretty weak. But typically, when I'm thinking of myasthenia gravis, I just go right to the eyes and the facial muscles primarily first. Treatment will be the anti-cholinesterase agents. Will provide some temporary improvement of the neuromuscular transmission, glucocorticoids to suppress the immune system, some immunosuppressant drugs, and plasmapheresis, which is the removal of the antibodies from the blood. Okay, Huntington's chorea. This one is a good one to Google on YouTube to look at Huntington's chorea and the gait that's associated with it. Um, it is a progressive atrophy of the brain, particularly in the basal ganglia and the frontal cortex. And there is depletion of GABA, which stands for gamma aminobutyric acid. It is an inhibitory neurotransmitter, right? Glutamate is typically an excitatory neurotransmitter, and GABA is more inhibitory. It kind of a very calming and inhibitory neurotransmitter. There are mood swings and personality changes that's associated with Huntington's disease. There's restlessness and choreiform, which means rapid and jerky movements in the arms, in the hands, in the face. This one could have some intellectual impairment. There are some personality changes, some moodiness, and some behavioral changes with dementia. So here's what the choreiform movements look like when they're walking. There's this writhing movement of the hands and the knees and the feet. The hands swing out. Sometimes it can go behind the face. There's spasms of the lips and the eyes and the mouth and the neck muscles. So again, this is one that's best seen on video to get a better understanding of it. And again, it's one of these that I'm sure you have seen in the past. The diagnostic tests, there is DNA analysis for any defective genes. Again, no current therapy to slow down the progression of it. It's just really symptomatic therapy. Some drugs to try and tone down the choreiform movements and some drugs to address the behavioral changes. We're going to finish up with spinal cord disorders, primarily focusing on herniated discs. The herniated intervertebral disc involves protrusion of the center, that nucleus pulposus, that can start to break through and protrude through the annular fibers. This can develop suddenly. It can also develop gradually with age, with obesity. The issues with this type of spinal cord disorder with the herniated discs is that there could be sensory issues. If the sensory part of the nerve is being affected, there could be motor impairment or atrophy or paralysis or weakness if the motor part of the nerve or even autonomic functions can be impaired, depending on which nerve the organ is going to. The most common discs to herniate are the lumbosacral, right, L4, L5, or L5 and sacrum, as well as the cervical discs, primarily C5 and C6. So here is the nucleus, right in the center. These are the annular fibers. These are pretty pain sensitive. When the nucleus starts to protrude and push through these annular fibers, it hurts. These are pain sensitive. And then it can push back in this direction, where you have in front, you have the anterior longitudinal ligament, and in the back, you have the posterior longitudinal ligament. And the PLL, or the posterior longitudinal ligament, is highly innervated. Now, if the disc pushes out in this direction and it hits this nerve root, if it hits the sensory part, then you get paresthesia, or numbness and tingling into a particular dermatome. If it hits the motor portion of the nerve, then there's weakness. Okay, so it's either pain, numbness, tingling, paresthesia, or weakness. And if it's really bad, then the reflexes become diminished. That's pretty bad. That's if it hits this nerve, it'll go down one arm or one leg, right? If this is the cervical, it's going to go down the arm. If it's a lumbar, it goes down the leg. If it pushes and it pushes back and hits the cord, you can have symptoms on both sides. When the disc pushes back and decreases the space where the spinal cord should be. They call it spinal stenosis. And they'll have this antalgic gait where they actually lean forward. You see it a lot in elderly where they walk, they're not standing erect, they actually have this forward lean. If they try and stand up, it hurts too much. And when they lean forward, it decreases the tension on the spinal cord. Okay. So let's see what else we need to cover here. Let's go on. So the degenerative changes in the disc can happen from age, meaning over a longer period of time. If there's metabolic changes going on, obesity, herniations can happen from trauma, it can happen from repetitious movements, it can happen from poor body mechanics and poor alignment, can happen from scoliosis, can happen from so many different things. I have known people that have turned their head to sneeze or cough that have herniated a cervical disc. I've known people who just hurt their lower backs from shoveling. I know people that hurt their lower back from simply bending over and picking up a penny. Okay? So it's the type of movement that can create it. Signs depend on the location and the extent of the disc protrusion. Most effects are unilateral. That's where just one nerve is being affected on one side. Large protrusions can affect both nerve roots, left and right, as well. CAT scan or MRI is diagnostic. The treatment is to reduce weight-bearing movement. In terms of MRIs, I prefer cervical and lumbar MRIs to be standing. They actually have stand-up MRI facilities. I'd rather have weight bearing on the disc to get a really good reading compared to recumbent lying down. I'd rather have 7 to 10 pounds of the head putting pressure on the neck, and I'd rather have the person's weight putting pressure on their lumbar spine to bring out the disc and not do an MRI lying down. It usually hurts in an upright position with weight and gravity. Applying heat, ice, and traction can be of benefit. There are drugs that are designed to relax the muscles and the pain. Physiotherapy, ultrasound, stim work very well. Chiropractic adjustments or manipulation work very well. Occupational therapy, traction, distraction to open up the discs and give it some breathing room. Very, very helpful. And in severe cases, when there's extreme atrophy, extreme pain, this is where they will do a laminectomy or a discectomy. And as a last resort, they'll do a spinal fusion to bring some relief. The problem with fusions is that you're decreasing mobility at a spinal segment. So if you fuse, let's say, L4 and L5, then what's going to happen above and below? They're eventually going to start to degenerate. If you fuse C5 and C6, what's going to happen above and below? When the movement at one segment is impaired, the area above and below have to compensate. And over time, those will eventually degenerate.